Welcome back to the deep dive. Today we are really shifting gears into high performance mode.
We are.
We're simulating a final review session for an MD anesthesiology candidate, and we're specifically targeting those grueling university exams, like the ones at Gujarat University.
A very specific focus today.
Exactly. And the topic on the table, the thyroid gland.
The ultimate exam topic.
It really is. I've been looking through the stack we pulled for this. We've got Morgan and Mikhail, Miller, Guyton for the pure physiology, Katie Tripathi for pharmacology, and even B.D. Churasia for the anatomy.
A full library.
And honestly, most people think, oh, it's just a little butterfly-shaped thing in the neck, but for an anesthetist, this gland is, well, it's a potential disaster zone, isn't it?
Absolutely. If you're sitting for your MD exams, the thyroid is not just an organ, it is a minefield. It's a favorite for examiners for a very good reason.
And what's that reason?
Because it tests three critical pillars all at once.
Mm-hmm.
Difficult airway management, cardiovascular stability during these metabolic storms, and some very, very intricate pharmacology.
So if you get a thyroid lung case, or that big 20-mark theory question, what is the examiner actually looking for? What's the subtext?
They want to know that you respect the physiology. That's number one. They want to see that you can handle an airway that might be deviated or worse, compressed.
Right.
They want to know how you'd manage a patient whose heart rate is just screaming along at 140 because of a thyroid storm. And they really want to know that you understand why giving the wrong drug at the wrong time can be fatal.
And these patients show up for surgery all the time.
All the time. And perioperatively, they are high risk.
Yeah.
Minor error in preparation, a little slip up, it can lead to a mortality right there on the table.
That sets the stakes incredibly high. So our mission today is to take this whole stack of textbooks and convert it all into a structured 20-mark answer and, more importantly, a bulletproof Viva strategy.
Let's do it.
Okay, let's start at the very beginning. Embryology. Why on earth does an anesthetist need to know how the thyroid develops in a fetus?
It's surprisingly high yield. I know it seems obscure, but the embryology dictates the airway anatomy you might face. It all starts as a median endodermal diverticulum.
Which is basically...
It's a little sprout. It sprouts from the floor of the primitive pharynx, right at the base of what will become the tongue.
Right at the foramen cecum. I remember that from anatomy.
Correct. And from that starting point, it has to migrate. It descends down the midline of the neck to reach its final resting place, just anterior to the trachea.
And it leaves a trail.
It does. It leaves a track behind it called the thyroglossal duct.
And normally that duct just disappears. But when things go wrong with that migration, we get anomalies that directly impact us, the anesthetist.
Exactly. And the most dramatic one, the one you have to know, is the lingual thyroid.
Okay.
This is where the migration fails completely. The gland never descends. It stays right there at the base of the tongue.
So you look in the mouth and...
You look in the mouth, or worse, you try to mask ventilate, and there is this massive, highly vascular lump completely obstructing the oropharynx.
That's a can't intubate, can't ventilate scenario just waiting to happen.
Precisely. If you see ectopic thyroid in a patient's notes, your brain must immediately scream, difficult airway.
What about the other big one, the thyroglossal cyst?
That's the other common anomaly. It's a midline neck swelling, and the classic sign is that it moves up when the patient sticks their tongue out.
Because it's still attached to the hyoid bone, right?
It's still tethered to its origin. So for a surgeon working on that, the track can go deep, very, very close to the airway.
Okay, so let's move the gland down to its proper home in the neck, anatomy. The texts love to describe it as a vascular sponge.
And that is a very fair description. It sits low in the anterior neck, around the level of C5 to T1 vertebrae.
Right.
It has the two lobes connected by an isthmus, and that isthmus usually lies right on top of the second, third, and fourth tracheal rings.
Which is vital to remember for a tracheostomy.
Absolutely.
Yeah.
You often have to retract the isthmus, or sometimes divide it, to get to the trachea. You have to know it's there to avoid a lot of bleeding.
Speaking of bleeding, let's get into the blood supply. This is where the surgeon gets sweaty, and the anesthetist really needs to be paying attention.
It's just incredibly vascular. You have the superior thyroid artery, which is actually the very first branch of the external carotid artery.
Okay.
And then you have the inferior thyroid artery, which comes up from the thyrocervical trunk, a branch of the subclavian.
But there's a wild card artery, isn't there? The thyroid ima?
Ah, the assassin artery. Yes. It's not always there, maybe in 3 to 10% of the population.
And where does it come from?
That's the problem. It can come directly off the aortic arch or the brachiocephalic trunk, and it shoots straight up the midline, right to the isthmus.
So if a surgeon isn't expecting it...
If they're doing a low tracheostomy or a thyroidectomy and they nick it, the surgical field floods with high-pressure arterial blood.
Yeah.
Instantly. It's a nightmare.
And what about the veins? They pose a completely different kind of risk, right? Air embolism.
Yes. The superior and middle veins drain, as you'd expect, to the internal jugular vein. But the inferior thyroid veins drain directly into the much larger brachiocephalic veins.
In the chest.
Right. So if there's a tear there and the patient is breathing spontaneously, they take a deep breath that creates negative intrathoracic pressure.
And it acts like a vacuum.
It sucks air right into the large veins, straight into the right side of the heart, a potentially fatal air embolism.
Okay, let's shift to what might be the most high-yield part of this, the nerves. This is the gold standard Viva topic.
You're right. You cannot pass a thyroid Viva without knowing this cold.
So let's start with the big one, the recurrent laryngeal nerve, the RLN.
The RLN. It runs in that little groove between the trachea and the esophagus, the tracheoesophageal groove right behind the gland. And it's very, very closely related to the inferior thyroid artery.
So it's right in the surgical field. What does it do?
It supplies all the intrinsic muscles of the larynx, except for one. It's what controls the opening and closing of your vocal cords, abduction and adduction.
So if you damage one RLN,
you get a unilateral palsy. The vocal cord on that side sits in a kind of halfway position, paramedium position. The patient will sound very hoarse.
and if you damage both,
That is an absolute catastrophe, bilateral RLN palsy. Both cords adduct. They just flop together because the only muscle that's still working is the cricothyroid, which is a tensor. It pulls them shut.
and the result is?
Stridor. Acute airway obstruction. That patient needs an immediate, definitive airway. Reintubation, maybe even a tracheostomy right there.
Which brings us perfectly to the other nerve, the external branch of the superior laryngeal nerve, the SLN. This is the one that supplies that cricothyroid muscle.
Correct. The cricothyroid is the tensor. It's the muscle that stretches the vocal cords to create high-pitched sounds. And this nerve runs right alongside the superior thyroid artery.
So it's also at high risk of being injured?
Very high risk.
And if it gets nipped, the patient isn't stridorous, right?
No, they're not. They can speak just fine. But they lose their upper register. They can't sing. They can't hit high notes. Their voice gets tired easily.
This is the opera singer's nerve.
Exactly. And in a Viva, this is a medical legal point, if your patient is a singer, a teacher, a lawyer, anyone who uses their voice professionally, you must document this function preoperatively.
Let's shift from the anatomy to the engine room. Physiology. How does this whole factory actually work?
Think of it as a very efficient assembly line. Step one is iodide trapping.
Okay.
The gland has these pumps, the sodium iodide symporter, or NIS, and it actively pumps iodide from the blood into the gland against a huge concentration gradient. This step is stimulated by TSH.
So we have the raw material, iodide, inside the factory. Then what?
Step two is oxidation. We have a crucial enzyme called thyroid peroxidase, or TPO. TPO's job is to turn iodide into iodine, the reactive form.
And that TPO enzyme is a key drug target for us.
It's the primary target for our main antithyroid drugs. We'll come back to that.
Okay, so we have iodine, then comes organification.
Yes. The iodine is then attached to tyrosine residues, which are on this massive scaffold protein called thyroglobulin. Then comes the final step, coupling.
Putting the pieces together.
Right. A monoiodotyrosine plus a diiodotyrosine gets coupled together to make T3. Two diiodotyrosines get coupled to make T4.
And then, unlike almost every other endocrine gland, the thyroid stores its finished product.
That's what makes it so unique. It stores a 2 to 3 month supply of hormone bound to thyroglobulin in the colloid.
That's a huge point. It's why you can't just switch off a hyperactive thyroid instantly with drugs.
Exactly. You can shut down the assembly line, but you still have to wait for the warehouse to empty.
Now, T4 is the main product off the line, but T3 is the one that does all the work in the body.
T4 is essentially a prohormone. It makes up about 90% of the gland's output. But T3 is about 4 times more potent.
And most of that potent T3 isn't even made in the thyroid.
Correct. Most of it is made in the periphery, in the liver, the kidneys, other tissues, by enzymes that strip one iodine atom off of T4.
Yeah.
This peripheral conversion is a massive concept for us therapeutically, isn't it?
It is our therapeutic loophole. In an emergency, like a thyroid storm, we can't stop the gland from releasing its stored hormone instantly. But we can block that peripheral conversion. We can stop the less active T4 from becoming the superactive T3.
And certain drugs do that specifically.
Yes. Drugs like propranolol, propylthiouracil PTU, and steroids all inhibit that conversion. It's a key part of our emergency management.
Okay, let's talk about the effects. When T3 finally hits the cells, what happens? We all know it increases the basal metabolic rate, but for us, as anesthetists, the cardiovascular effects are the real headline.
They absolutely are. Thyroid hormones at a molecular level upregulate beta-adrenergic receptors on the heart muscle. They essentially stud the heart with more receptors.
They make it more sensitive.
Exactly. So even if your circulating adrenaline and noradrenaline levels are normal, the heart reacts as if it's in a full-blown sprint.
Huh? What does that look like clinically?
Tachycardia, a big increase in contractility, increased cardiac output, and a widened pulse pressure. It perfectly mimics a sympathetic storm.
And what about the respiratory system?
Well, the body's metabolism is in overdrive, so it's consuming a lot more oxygen and producing a lot more CO2. The thyroid hormone increases the central ventilatory drive to match that demand. The patient has to breathe faster and deeper.
Got it. Okay, let's look at when things go wrong. We'll start with the low and slow side of the spectrum, hypothyroidism.
This is a state of hormone deficiency. The most common cause is Hashimoto's thyroiditis, which is an autoimmune destruction of the gland. Or it can be iatrogenic after we've surgically removed the gland or given radioactive iodine.
What are the systemic effects that we need to have front and center in our minds for the exam?
Cardiovascularly, everything is depressed. Bradycardia, decreased contractility, very low cardiac output. A classic exam sign you have to mention is a pericardial effusion.
Right, and it's a specific type of effusion.
Yes, it's rich in protein and cholesterol. And on the ECG, you'll classically see low-voltage QRS complexes.
And what about the airway in these patients?
This is a big one. You can get macroglossia, a large, swollen tongue, and you also get a general myxedematous thickening of all the pharyngeal tissues. It can make intubation surprisingly difficult.
So physiologically, they're cold intolerant, they're prone to hypoglycemia, and also hyponatremia. How does all this translate into our anesthetic management?
The first rule is simple. If it is elective surgery, you cancel. You postpone until the patient is euthyroid. The risk of profound hypotension, cardiac failure, and dangerously prolonged drug effects is just too high.
But in an emergency, we don't have that luxury.
No. In an emergency, you have to proceed with extreme caution. The single biggest risk is on induction of anesthesia.
Why is that?
Because these patients have blunted baroreceptor reflexes, and they're often intravascularly volume depleted. If you push a standard induction dose of propofol or thiopentone, their blood pressure will just fall through the floor. They will crash.
So go easy on the induction agent.
Very easy. And consider using agents like ketamine or etomidate, which are more hemodynamically stable. And you have to be incredibly careful with opioids and sedatives. Their respiratory drive is already depressed. They are exquisitely sensitive to narcotics.
Now let's talk about the worst case scenario here. Myxedema coma.
This is a true medical emergency. It's a life-threatening decompensation of severe hypothyroidism. You see a triad of altered mental status, profound hypothermia, and cardiovascular collapse.
And there's a very famous Viva trap regarding the treatment protocol, isn't there?
Yes, and if you get this wrong, you fail the station. You must give steroids hydrocortisone before you give thyroid hormones.
Why is that specific order so absolutely critical?
Because of something called Schmidt syndrome. It's the coexistence of autoimmune thyroid disease with adrenal insufficiency. Quite common. If you rev up their metabolism by giving them a big dose of T4 without first supporting their adrenals, you will precipitate an acute adrenal crisis.
And that's fatal.
You will kill the patient. So the mantra is, steroids first, always.
Got it. Now, let's flip the coin completely. Hyperthyroidism, thyrotoxicosis, the high and hot state.
Right. Usually this is caused by Graves' disease, where autoantibodies actually stimulate the TSH receptor. These patients are completely hyperdynamic.
So what do we see?
Tachycardia is a given. Atrial fibrillation is very common, maybe in 10 to 15% of cases. And if it's left unchecked, they can go into high-output cardiac failure.
And for these patients, what is the golden rule for surgery?
The golden rule is a euthyroid state is mandatory before any elective surgery. There are no exceptions to this rule. Taking an uncontrolled hyperthyroid patient to the operating room is like personally inviting a thyroid storm to the party.
So how do we optimize them? There's this 6 to 8 week preparation period.
That's right. The first thing you do is start them on antithyroid drugs, the thionamides. That's either propylthiouracil, PTU, or methimazole.
And what do they do?
They both work by blocking that key enzyme, thyroid peroxidase, or TPO. So they shut down the synthesis of new hormones.
But PTU is often preferred in acute, severe situations over methimazole. Why is that?
Because PTU has a superpower. It also blocks the peripheral conversion of T4 to T3. Methimazole does not. That gives PTU a much faster onset of action in terms of lowering the levels of the active hormone.
Okay, so we block synthesis, then we add beta blockers.
Yes. Propranolol is the classic choice. It's used to control the heart rate. Our target is usually less than 85 beats per minute, and it also helps with the tremors. And like PTU, propranolol also has the beneficial side effect of inhibiting that peripheral T4 to T3 conversion.
Right, so it has two mechanisms.
Exactly.
And finally, right at the end of the prep, we add iodine, Lugol's iodine, but only at the end.
Yes, and this is the second big Viva trap, the iodine timing trap. You must block hormone synthesis with the thionomides first.
What happens if you don't?
If you give a big dose of iodine to a hyperactive gland, it will just use that iodine as fuel to make even more hormone. That's called the Jod-Basedow effect.
Yeah.
It'll make the thyrotoxicosis worse.
But if you give it after blocking the factory?
Then it has a different effect, the Wolff-Chaikoff effect. It actually inhibits the release of stored hormone. And very importantly for the surgeon, it makes the gland much less vascular and easier to operate on.
Okay, so the patient is optimized. Intraoperatively, for this hyperthyroid patient, our main goal is to avoid any sympathetic surges.
Any stress response.
Yeah.
So no ketamine, no pancuronium, which is vagolytic, no epinephrine in the local anesthetic solution if you can avoid it. You need deep, smooth anesthesia to blunt that stress response.
And if we fail, if despite our best efforts, they decompensate and go into a thyroid storm?
This is one of the biggest emergencies we face. You'll see hyperpyrexia, a temperature over 40 degrees Celsius, severe tachycardia, often over 140, agitation, delirium, and eventually cardiovascular collapse.
How do we manage? There's a mnemonic, right? The 4 Bs.
That's a good way to remember it. So,
Okay.
number 1, block synthesis. You give PTU, usually via an NG tube, or you can even give it rectally.
Okay.
Number 2, block release. You give iodine, but remember you have to give at least 1 hour after the PTU dose.
To avoid fueling the fire.
Precisely. Number 3, block the beta receptors. You need to control the heart rate. Intravenous esmolol is great because it's short-acting and titratable, or you can use IV propranolol.
And the 4th B.
Block conversion. And we're already doing that with our other drugs, the PTU, the propranolol, and you should also give hydrocortisone, which also helps block that T4 to T3 conversion.
And what about cooling the patient? They're hyperpyrexic.
Yes, aggressive cooling. But there is a very specific drug contraindication here that they love to ask about.
Don't say aspirin.
No, aspirin, absolutely not. Aspirin actually displaces T4 from its binding proteins in the blood. That increases the amount of free active hormone. You are literally pouring gasoline on the fire.
So you use paracetamol and external cooling blankets.
Yes.
Okay, let's move to the surgery itself now, thyroidectomy. The preoperative assessment is all about looking for mechanical obstruction from the goiter.
It is. You need to look for any signs of tracheal deviation or compression. A chest x-ray is a minimum, but for large goiters, a CT scan of the neck and chest is mandatory.
And you have to check for a retrosternal extension of the goiter. There's a clinical sign for that.
Pemberton sign, a classic.
And that's where the patient lifts their arms above their head.
Yes, they raise both arms until they touch the sides of their head. This motion lifts the goiter up and can wedge it into the thoracic inlet. If it plugs that inlet, you'll see the patient's face become congested and plethoric, maybe even feel dizzy.
And a positive Pemberton sign tells you.
It tells you that there's a very high risk of total airway obstruction on induction of anesthesia when they lose muscle tone.
Okay. Anesthesia technique for the thyroidectomy itself. General anesthesia is the standard. What are the key considerations for the endotracheal tube?
We almost always prefer a reinforced or a flexometallic tube, an armored tube,
Why?
because the patient's neck is going to be extended in the rose position, and the surgeon is going to be manipulating and retracting the trachea. A standard PVC tube can easily kink or be compressed. The armored tube is much safer.
And tell us about that position, the rose position.
It's head up with marked neck extension, usually with a sandbag placed under the patient's shoulders. It gives the surgeon fantastic exposure of the neck, but it has risks. It does. You have to be careful not to overextend, especially in elderly patients with cervical spondylosis. You can risk cervical spine injury or even vertebrovascular insufficiency. And always protect the eyes.
Intraoperatively, we're watching for the storm, but there are also reflexes we need to be aware of.
The carotid sinus reflex. The surgeon is working right next to the carotid sheath. If they put too much pressure or traction there, it can stimulate the baroreceptors and cause profound bradycardia and hypotension.
And the first step in treatment is?
Communication. You tell this surgeon, stop manipulation. That's usually all it takes. If not, then atropine.
Let's talk about getting out of the OR, postoperative complications. This is another really high-yield area. What are the killers in the recovery room after a thyroidectomy?
The single most immediate, life-threatening threat is a hematoma.
A bleed in the neck?
Yes. The thyroid bed is incredibly vascular. If a ligature slips, blood can accumulate very, very rapidly under the strap muscles.
And it's not just that it compresses the trachea directly.
No, that's a later sign. The first thing it does is compress the veins, causing massive venous congestion and laryngeal edema. The airway swells shut from the inside. It is a true airway emergency.
So here is the classic Vivas scenario. You are called urgently to the ward. Your post-thyroidectomy patient's neck is swelling rapidly. They're gasping for breath. The SATs are dropping. What do?
This is the ultimate test. If you say, I'll call the surgeon, or I'll rush them to the OR, or I'll get an urgent CT scan, you fail instantly.
Yeah. So what's the pass answer?
The only correct answer is, I will immediately open the sutures at the bedside to relieve the pressure.
You're opening the neck right there on the ward.
Yes. With a stitch cutter or a scalpel. You open the skin clips or sutures, you part the wound, you scoop out the clot with your fingers. The bleeding will still be there, but you have released the tension. You have saved the airway. Then you can focus on securing the airway and getting them back to the OR.
Decompress first, ask questions later.
That's the rule.
What are the other major complications?
Well, recurrent laryngeal nerve palsy, which we've already covered, and the other big one is hypocalcemia.
This happens because the parathyroid glands were accidentally damaged or removed.
Exactly. It doesn't usually manifest immediately. It's more of a 24 to 48-hour post-op problem.
What are the signs?
The earliest sign is often perioral numbness, a tingling around the lips. Then you can check for the classic signs. Schwastek's sign tapping the facial nerve causes a facial twitch, and Trousseau's sign inflating a blood pressure cuff causes carpal spasm.
And if it's severe, it can cause
laryngeal spasm, which is another post-op airway emergency. The treatment is IV calcium gluconate.
There's also one more rare but dangerous airway issue, tracheomalacia.
Yes, this is rare. You see it in patients who have had a massive long-standing goiter that has been compressing the trachea for years. The tracheal rings can become weak and floppy.
So when you extubate them,
the trachea just collapses like a wet noodle. These patients might need prolonged intubation or even a tracheostomy.
Just a quick note on the ICU. We sometimes hear about sick Euthyroid syndrome. What is that?
It's also called non-thyroidal illness syndrome. In any critically ill patient with sepsis, trauma, burns, you'll see their T3 level drop. Their T4 and TSH can be normal or low.
And we should treat it.
No. This is thought to be an adaptive, protective mechanism to conserve energy during critical illness. The current consensus is do not treat with thyroid hormone. It doesn't improve outcomes and might even cause harm.
And what about regional anesthesia? Can you actually do a thyroidectomy under a block?
You can. It can be done under a bilateral cervical plexus block. The main advantage is that the patient is awake, so you can continuously monitor their voice and test the RLN function in real time.
But the risks are pretty significant.
Very significant. You can easily get a phrenic nerve block, which paralyzes the diaphragm on that side. So you would never do it in a patient with severe COPD, and you have the risks of accidental injection into the vertebral artery causing seizures or even a subarachnoid injection.
Okay, let's wrap all of this up with a concrete exam strategy. If a student gets that 20-mark long answer question, discuss the anesthetic management of a patient for thyroidectomy, how should they structure it?
Structure is absolutely everything. First, a brief introduction. State that the key concerns are airway, metabolic control, and specific pharmacology.
Then what?
Then anatomy and physiology. Briefly hit the high points.
Right.
The vascular supply, mentioning the EM artery and the nerve relations. Then preoperative assessment. This is a huge section. You must focus on the airway Pemberton sign, CT scans, and achieving a euthyroid state. Detail that 6 to 8 week prep for the hyperthyroid patient.
Okay.
Then intraoperative management. Talk about the potential for a difficult intubation, the choice of a reinforced tube, the rose position and its risks, and your drug choices to avoid sympathetic stimulation.
And after that, the complications.
Yes, your post-operative management section must detail the management of a hematoma, emphasizing immediate bedside decompression, as well as RLN injury, hypocalcemia, and thyroid storm. Then a short conclusion to summarize the key safety points.
And for the Viva, what are the safe answers that will always get you points?
There are a few key phrases. I would postpone any elective surgery until the patient is clinically and biochemically euthyroid.
Good one.
I would perform a thorough airway assessment, specifically looking for signs of compression or deviation.
Okay.
I would ensure vocal cord function is documented preoperatively. And the big one, For a rapidly expanding neck hematoma, I would decompress the wound at the bedside immediately.
And you mentioned diagrams. What should they be practicing drawing?
You need to be able to draw a simple cross-section of the neck, showing the thyroid's relationship to the trachea, the esophagus, and the carotid sheath with the RLN in the groove. You should be able to draw the HBT axis with its feedback loops. And for the emergencies, a simple flowchart for the management of thyroid storm is exam gold.
Okay, let's do a final super rapid-fire, high-yield recap. The thyroid is fundamentally
An airway organ. You have to respect the lingual thyroid, the large goiter, and the post-op hematoma.
hyperthyroidism means.
You have to fear the storm, optimize the patient with PTU, beta blockers, and then iodine, and always in that order.
Hypothyroidism means.
You have to anticipate the crash, be wary of hypotension on induction, and remember, steroids before T4 in a myxedema coma.
And post-operatively.
It's all about vigilance. A hematoma requires a blade, not a scanner. Hypocalcemia presents with pingling, and absolutely no aspirin in the thyroid storm.
This has been a massive, really comprehensive review. We've covered the embryology, the pharmacology from Katie Tripathy, the deep physiology from Guyton, and all the clinical management from Miller and Morgan.
It is a heavy topic, there's no doubt about it. But if you respect the physiology, know the anatomy cold, and anticipate the complications, you will pass the exam and, more importantly, you'll keep your patients safe.
To our listener tuning in, our advice is to go draw those diagrams right now. Good luck with the preparation.
Safety first, always.
We'll see you in the next deep dive.